we do the barium studies for the gut to know what's happening in the stomach and bowel. I was doing all of that. I was doing ultrasounds of pregnant women. I was doing antenatal, we call them antenatal ultrasound. So I was doing that. I was doing regular ultrasounds. I was looking at CT scans. I was reporting MRI of the brain, spine, the shoulder joint, the prostate. I was doing everything. But as we move forward, you got to, because the medicine and each branch of medicine has grown so much in its, the vastness of subject is so much that if you remain a general radiologist for long, it doesn't take you anywhere. Number one. Number two, probably with the kind of developments in every sphere, in every organ, you're not going to be best in doing that. You will be able to report to a certain extent, but you may not be the pinnacle of knowledge and competence in every branch that, if you're handling everything, say MRI, CT, you're doing everything. It's like jack of all trades. And
Nikala, your voice is cracking. So your voice is cracking. You'll have to come closer.
Yeah, now it's better.
So you'll have to repeat what you just said. I can't.
So what I'm saying is, with the development of science and the vastness of knowledge that is available now, and with the advancement of the technology in imaging, there is so much about every organ that is happening, So we are in an era of subspecialization where I do radiology, and then within radiology, we have abdominal imaging, chest imaging, neuroimaging, neurointerventions, interventional radiology, and breast radiology. So it was, as I progressed for about 7 to 8 years, I was a general radiologist. Then an opportunity came in my own organization where they were looking for someone to specialize in breast. And I, being the senior female radiologist in the department, I was asked to go and, train in breast imaging and come back and develop that specialty in my hospital. And then by then I had done quite a bit of general, imaging. So I said, why not? I said, why not? Let me go train and come back and see how I do with my training and how good I am at that, And then I thought, well, I take it forward. And then there's been no looking back, thankfully.
You are associated with Krishna Institute of Medical Sciences, as we know it as KIMS. What are the various aspects that you deal with in breast cancer? What I'm talking about is there are 4 stages, as I know, is in breast cancer. So what is your area of work in terms of all the stages of breast cancer?
So we at KIMS, as you already know, are our advocacy of early breast cancer screening and early pickup of breast cancer has been our campaign and motto right from the time that the unit was established in KIMS, right? So what is early breast cancer and what is breast cancer screening? Early breast cancer is that when the breast cancer, the size of the cancer in the breast is less than a centimeter or a centimeter and a half. Now, why is it important to pick up a cancer that early? When it is 1.5 centimeters, it's barely palpable. So what I'm saying is, we want to pick up cancers even before they become palpable to the surgeon's hand or to the hand of the woman. We always spoke about self-breast examination. I'm talking of something even before something is felt by self-breast examination.
Okay.
There have been a lot of randomized controlled trials done in the Europe and US, where they have found that if you pick up a cancer which is less than 1.5 centimeters, and if the cancer has not spread to the lymph nodes in the armpit, then the 5-year survival rate of this woman is more than 95%. Now, what do I mean by that? I mean, not even 5 years, the 12-year survival rates are between 95 to 98%. Means you're practically talking in terms of cure. So very rarely we use the word cure in the cancer setting. But if this is a screen detected cancer,
Mhm.
then I can assure the patient that she is not going to succumb to this cancer
Sure.
with,
Sure.
with confidence, you know. So my job entails, it's two things. One is screening for breast
Mhm.
cancer. Number
Mhm.
two, diagnostic studies, which means
Mhm.
that the patient has a complaint, say a
Mhm.
lump in the breast or a
Mhm.
nipple discharge or a
Mhm.
simple pain, cyclical pain. Every month they have this very severe pain in the breast.
Right.
So they could come up with any complaint and then we evaluate it.
Sure.
The other limb is woman who's turned 40, and then
Mhm.
she just comes to the unit to know if she's well, if everything is fine in the breast. So they
Sure.
just come to do a mammographic screening.
Mammography.
So
Right.
I look at the mammogram, and then if I feel that she would benefit with an ultrasound of the breast, I
Okay.
add that also. If I find something, then I sit them down, counsel them that I've found something which may need further examination in terms of biopsy, where we take out small bits of tissue, send them for diagnosis, and then depending on what the diagnosis is, we tell them what is to be done next, right?
Sure.
Gone are the days where women felt a lump, they go to the surgeon, nothing is done, the surgeon will remove the lump, send it for testing, and come back and say, okay, it turned out to be a cancer, so you need a second surgery. So
Okay.
this is now archaic. This is
Okay.
vintage. We do not practice that medicine any longer.
Right. I
Every
like the way
woman,
you put it.
yeah,
Yeah. So
yeah,
in the day and age that we live in today, like a lot of young women want to delay their marriage and also delay their childbirth. Uh, if a woman has breast cancer, can she nurse a child?
yes, she can. I mean, depending on what kind of surgery she has chosen. Suppose it's a mastectomy, obviously she cannot, there's no breast there, so but she can comfortably feed from the other breast. And depending on whether it's an out, if she has conserved her breast, and
Mhm.
if there is milk let down from that breast, even after radiation, because one must understand that once they choose to do a breast conserving surgery, meaning only the lump and a centimeter of tissue around the lump is removed,
So,
and it is always followed by radiation to the breast. So even after that, if there is milk production from that side of the breast, she can comfortably nurse the.
right.
There's nothing stopping them from nursing the baby. They can
Right.
very well nurse the baby.
Right. My second follow-up question to the same question is: so she's had a tumor, she's gone through a surgery, she's not yet gone through chemo or radiation. Can she nurse the child?
She can. She can. Very well.
Sure.
She can. There's uh,
What?
there's no relation to cancer, and once the cancer is removed and she's well, she can nurse the child.
She can
And
nurse
it's
the
not
child. All
like
right.
the cancer cells are going to get into
The
the
baby.
milk, and these are all
Right.
just misconceptions that people have. But
Right.
as long as there is production, and because see, some ducts are going to get injured while the surgery is done. So if the other ducts which are intact are still producing milk, very well she can nurse the child.
All right. I mean, I'm sure these questions may be simple for you, but I would like to answer it
Yes,
on
no,
behalf
no,
of
no.
all the audience.
These are a lot of myths and misconceptions that women have, and this adds to that fear.
Yeah.
That
Yeah.
fear that they have. Yeah, so it's always nice to dispel these myths. Yeah.
Doctor, you have been in radiology for many, many years now. You must have seen patients like my sister who just breezed through it, patients who are, what is anxiety driven, very, very scared of even a needle. So, how do you counsel them? What are the various things that a patient should understand before she even approaches you?
See, frankly, fear gets them nowhere. I have these women who feel a lump when it is probably just about 2.5 centimeters.
Right.
the fear of biopsy and the fear
The
that
needle
this
itself.
might turn out to be a cancer. Forget about the needle, the fear that, if I go and present myself to a doctor, and if this turns out to be a cancer, so they're going to remove my breast, my hair is going to fall away. So thinking of all of this, they don't even step out of their house to even get themselves examined in the first place.
Right.
For all you know, it could be an infected cyst. It could just be a fibroadenoma, a non-cancerous lump. They just sit on that. Now, unfortunately, what happens is, as you said, there are 4 stages in breast cancer. So once the cancer jumps from one stage to the other, the prognosis meaning the life that they have after treatment with cancer, the disease-free life, the recurrence-free life, or the longevity they have after cancer therapy keeps coming down.
Right.
If I say screen-detected cancer, 95 to 98% 12-year survival rate, I'm not going to talk in 90% when I'm talking about a 3-centimeter cancer. I'm not going to talk about survival rates in stage 3 or stage 4 disease. I'm not even going to talk about 12-year survival rates. We are only talking about 5-year survival rates, right? So the fear is going to get them nowhere,
Sure.
So but unfortunately, yes, you'll be surprised. We think education equips and empowers these women. No, education has nothing to do with this. It is the way they are, the way they are made, and also
Society
the
plays a
family, the
yeah.
family that they are surrounded.
Right.
The family plays an enormous role
Vital.
in all of this.
True.
Talking to them, convincing them, the children, you're talking about a 45, 48-year-old, probably she has a 20, 22-year-old daughter or a son. So, having that relationship where she can openly talk about what she has, and for them to pay attention, pay heed to what she's saying, bring them to a hospital, and then, it requires a lot of talking and convincing, but that's what we are here for,
Right.
So we tell them that for all it may not be anything. Just give me that half an hour of yours, and we will tell you what's wrong with you,
Sure.
So, yeah, we have to convince them to do what is right for their own good. Yeah.
So, even the educated urban society women don't understand what is breast cancer or don't understand how to examine themselves. Point 1 is, what do you suggest for them? Point 2 is, what if I know it and I'm like, I'm scared of needles. I don't want to, I understand cancer means death. So I don't want to go and approach a doctor. So how do you address my 2 questions?
See, number one, knowing what is normal for you is very important. Normal meaning, how does your breast feel before your cycle and after your cycle? Because you must understand, breast is an extremely dynamic organ. Like, see, we understand that every time a woman menstruates, and it's a cycle of ovulation, and then 15 days later she has her period, and she knows ovaries have ovulated and the uterus lining is shedding away. But what we don't understand is, along with all of this, the breast is also undergoing its own changes, because the breast, every cycle is preparing for pregnancy. The breast is preparing itself to produce milk. Those hormonal estrogen, progesterone, all these are having an effect on the breast also. So it's important to know what is normal for you. How does your breast feel before the period and after the period? Now is the era of breast cancer screening. So any woman who is over the age of 40, we advise that they go for a mammographic screening once a year until they're about 60. And after 60, we would call them biennially, once in 2 years, right? With or without ultrasound. That depends again on how your breast is composed. So we add an ultrasound. Now, below 40, my advice would be to do a self-breast examination every month while you're taking a shower. There are umpteen number of videos on YouTube which explain to you how you have to examine your breast and know what is normal for you and what is a normal variation that happens to your breast with your menstrual cycle. Because unfortunately, under 40, if you do not have a family history of breast cancer, we do not offer mammography or any form of breast cancer screening. But having said that, in our country, more and more we are seeing women between the age of 30 and 40 coming with breast cancers. So I really can't say that, you don't have to do anything. Don't do screening. Don't do self-breast examination because it is no longer scientific. We have to offer them something, after they are 30. So I believe that between 30 and 40, definitely a self-breast examination would pick up a lump, if not screen detected, at least when it is less than 2 centimeters, let's say.
Sure.
All right. Even then, it's a T1 tumor. It is still a T1. Anything below 2 centimeters is a tumor which is stage 1.
Right.
And most likely it has not spread to the lymph nodes. Right?
So that was my question. Next question. You rightly mentioned, people within the women between 30 and 40 years. Today, we find young women, late 20s or early 30s, having breast cancer. What are the reasons? Is it just lifestyle or is it food?
I strongly believe if you take out the genetic predisposition, okay, there is a subset, about 10% of cancers are genetic. One must understand that if you have a family history of breast cancer or ovarian cancer, you may be predisposed to have a breast or an ovarian cancer or rarely a colonic cancer. All right. So family history meaning grandmother on both sides, paternal, maternal, aunts, maternal aunts, paternal aunts, and your own mother and sisters. So this forms the family history of breast cancer. Right now, if we take out that subset of people who have family history of breast cancer, the rest are all these sporadic cases of breast cancer for whom we really don't have an explanation in this time as I speak. But we surmise that it has got to do with it's either from the air, the Panchabhuta, as I would say. I always say, what is body made of? After all, it's made of these 5 elements. It's the air, the water, the food. Indirectly, the food comes from the soil. So it has to come from any one of these.
And again, the soil is filled with chemicals and
chemicals,
pesticides,
pesticides. So plastics, are being blamed in a very big way for many, many cancers, especially the female cancers, because these are all estrogen dependent. And there's a theory that these plastic molecules mimic estrogen and the body senses it as exogenous estrogen and reacts to it as if it would react to it.
If my family member, my sister, my mother, my maternal cousins, maternal grandparents, grandmothers specifically have cancer, am I a high risk patient?
Certainly. So, how we stratify risk is that we look at first degree and second degree relatives. First degree meaning mother and sister, your immediate blood relations, your mom and your sisters, older or younger sisters. And second degree would be your mom's sister or your grandmother. Third degree would be your cousins, your aunt's daughter or your masi's daughter, your bua's daughter. That would be third degree. So we say that if you have a single first degree relative who was diagnosed with breast cancer under the age of 40, then you're straight away a high risk.
Sure.
Then if you have two second degree relatives under the age of 50, then you're a high risk.
Okay.
Now, you can ask me, so what? Why is this important?
Right.
This is important because I'm not going to be recommending you the same set of tests in the same interval as I would recommend to a person in the general population. Because when we say high risk, the chance of this person getting a breast cancer is close to 20 to 25%. Lifetime risk is 20 to 25%. And when we say average risk, we are talking about 10 to 12%. Okay. So you carry a double or twice the risk of breast cancer than the general population. So the kind of tests I'm going to do on you are going to be different. And the time intervals are also going to be much shorter. Right?
What do you mean by time intervals being shorter?
See, for the general population, as I said, some countries recommend breast cancer screening once in a year after the age of 40. Some countries recommend once in 2 years, and some others recommend once in 3 years. Depending on which country you live. But unfortunately, in India, we do not have population-based breast cancer screening programs, because the scientific explanation for that is that breast cancer incidence has not attained such proportions that it can be added in a regular screening program. Okay. Right? So, but then, as doctors and specialists, we see so much happening around us that we don't think we are very far away from that day when, breast cancer is going to take, is going to take epidemic proportions, right? So yeah, that is scary. That is scary, really, believe me. So as on today, what we recommend is an annual mammogram for the general population, an annual mammogram starting the age of 40, at least till 60, and then you can come once in 2 years. Okay. But if you qualify as a high risk for breast cancer, then the recommendations as we speak today are that I see you every 6 months. Got it. So I do a mammogram and an MRI of the breast at 6 monthly intervals. Okay. Right? So I'm seeing you every 6 months. So if you see me in January, for example, I do a mammogram. And then I bring you back in July for an MRI of the breast. Okay. And then take you, do a mammogram in the following January. So I see you every 6 months so that I do not miss cancer that has started, assuming that, today you're well and tomorrow something is started. 6 months is not too far away to get a control on the disease. Okay. So that's where we are today.
What is the difference between ultrasound, MRI, and CT scan?
Okay. Ultrasound is where we use the sound waves. Technically, we use the ultrasonic waves in the frequency of about 3.5 to 15 megahertz, depending on which organ you're interrogating or which organ we are examining. All right. So in ultrasound, we have a transducer, a probe. You must have gone through that ultrasound, right? There is this funny little thing that we rub on
like a mouse
with a gel. Yeah, very, very similar to a mouse. So that emanates ultrasonic waves which hit the organ and then get reflected. So for abdomen and deeper structures, we use higher frequency, obviously, because frequency is indirectly proportional to penetration. So if we want more penetration, we want lesser frequency. Right. Now, if I'm examining your thyroid gland, or I'm doing an ultrasound for, these IT guys have this carpal tunnel all the time, I know, that's why I'm saying that. So you guys are on the laptops and mouse. So if I have to see what's happening in your carpal tunnel, then I don't want too much penetration, right? So I'm going to use high frequency for superficial structures and lower frequency for deeper structures.
Okay. So in fact, I have a carpal tunnel syndrome.
So you need an ultrasound. So ultrasound is no radiation. So as I said, we use ultrasound, ultrasonic waves, which do not carry any radiation hazard with that. So we can perform them. It's more easily available. Of course, it is operator dependent because it depends on how much knowledge I have, how much competence I have in interpreting what I'm seeing on my monitor. right? And then whether I have actually looked at that organ that carefully or not. It is not automatic. It is operator dependent. It depends on the skill of the person who is performing. Now, the next is CT scan. CT scan is again an X-ray based investigation. We used X-rays to do our chest X-ray, a simple X-ray, or a broken bone or a painful back, you do an X-ray or radiograph. So we use the same X-rays, but here what we do is we take cross-section of the abdomen or the brain, we slice it slice by slice and get sections of the body, and we interpret those images. So these are all black and white and shades of gray.
Sure. When you what Srikala mentioned was slice is not cutting slices into like beans or bendi, but slicing in terms of the imaging.
Images. I'm getting a slice by slice image of the organs in the body, right from the skin to skin. So I'm able to see the liver. It depends on how much thickness I have in my setting. Depending on the indications, it's too technical, but that is what we do. We get a slice by slice image of the chest, the abdomen, the brain, the legs, the thighs, the pelvis, all of that. But this involves radiation. So, CT scan became extremely, a household discussion thanks to COVID. Everybody knows CT chest, that is the investigation to diagnose COVID. Sure. So we all got a lot of radiation thanks to COVID. But yes, if there is one investigation that one has to be really wary about in terms of radiation dose, it is CT scan.
All right. Can a lady get breast cancer post-menopause?
Absolutely. Absolutely. Breast cancer, if we are not talking about the young cancers, is a disease of the peri and postmenopausal women. Theoretically, I would say, because I've seen so many young now, I don't want to scare people who are watching me, but then, yes, we are looking at a different disease. The disease is evolving into a different one now, but historically and in general population, it is a disease of the peri and the postmenopausal women.
Menopause, yeah. What Srikala is definitely not scaring, but more educative to the audience, to the young audience out there. Young professionals, both students and young professionals who are not aware of breast cancer. She's just explaining in detail and not scaring anybody.
Yeah. Awareness and knowledge is power.
Absolutely.
No matter what your age, you could be 22, 25, 28, 30, 30.
Or even 58.
Anything, you're a woman, you have breasts, you're at risk.
Right.
So anytime you feel something different, it's always wise to go examined, get evaluated. That's all that I'm saying.
Sure. As a radiologist, as a doctor, what are the three very exciting things that you have faced in your career? And what are three challenges that you have faced?
Three exciting is...
Exciting, or, that adrenaline jump.
When you're doing your post-graduation and you're training in radiology, of course, in your house job, you do deliver babies in the labor room posting, and you see the babies, the newborn babies. I mean, it's amazing to, as a 23-year-old to hold newborn, which you have delivered in the labor room. I mean, that's amazing. But to add to that, I ended up doing radiology where I tell the woman that she's pregnant, and I see the baby from the time it was conceived to probably a day before it is delivered. And there are times when I've seen the baby, I've scanned the baby a day after it's delivered. So I've seen the entire journey from the time that it was conceived, and it's looking at you in flesh and blood. The baby is staring at you. I mean, I cannot explain that, that feeling that it gives me. It's extremely very gratifying, and You feel so blessed. You feel so
But
blessed.
as radiologist, what are the 3 exciting things that you went through?
Yeah. So when I tell a woman, somebody longing to have a baby, and I tell them that you're pregnant, I see the joy in their face. And when they deliver the baby, they come to you and say, "Doctor, this is my baby." Oh, that makes me amazed.
True.
And the other one was when I first diagnosed the first screen detected breast cancer. I remember the lady's name. I cannot reveal for the reasons of anonymity. She was a 50-year-old unmarried lady who was staying with her brother and was working for the national, the NFC. So as a part of our screening, when we started off, we had this bus which was going to all these organizations, a mobile van where we were getting women to do breast cancer screening. So she was 50-year-old and she came and I read her mammograms a couple of days after it was done. And I picked up this little 5 millimeter area of distortion. So we sent a message to the NFC saying such and such woman who came for her screening needs an additional test. So she came to us. She stays with her brother and family. And I did the biopsy. Okay. And imagine doing a biopsy of a 4 millimeter tumor. It's as good as it can get, and tough. That was my first case after my training, and the gap of size. It's really tiny. And there was a gap of 6 months between my training and me starting to do breast cancer screening. So I was not sure of my skills, and I did get the right tissue. And my pathologist called me and said, "See, you must understand that unless I pick this up and I biopsy it, my pathologist is not going to get a chance to see such a small early cancer." Got it. We are as good as what we see and we get as a clinical material. So my pathologist called and said, "Jwala, I have not seen a cancer as early as this in ages." So she confirmed that it was an early cancer. This was in 2007, December. And believe me, she was in my office 4 months ago, about 6 months ago. And she's doing absolutely fine. She's now 2007 to 2023, 16 years. She's 66, 67-year-old, absolutely fine. And then more, that's, God has given me this opportunity to save a life. I'm so fortunate that, I have this opportunity to make a difference in a woman's life. Sure. It's absolutely thrilling. And
what
number 3
challenges you had?
Sorry?
What are the challenges you went through?
Challenges are difficult patients. Are, the minute you say, I see something, they just break down, and it's so difficult for them to, it's a process. Somebody just walks in thinking, she knows everything is going well in her life. She has a beautiful family. Children are doing well. Husband is extremely supportive. She just walks into the clinic, assuming everything is fine. And here I am telling her across the table, the dear lady, this is wrong with you. This is a cancer, unfortunately. Believe me, it's not easy. It's not easy because I'm a woman. I have a family. I have a young family. And you know how important a woman is to the household. Everything revolves around.
Yeah, she's the fulcrum.
Holds everything together. And to see them crumble and just, be devastated in front of you is not easy at all. It is extremely challenging. No matter how many hundreds or thousands of women I would have spoken to, every day it is different. And for me, she is an N number, but for her, it's only me. And
for you also, she's a new case. She's a new person to deal with and emotions to deal with.
Some people say, "Doctor, oh yeah, you see so many every day. For you, it's nothing." No, it's not like that. It's not like that, because I understand that I'm the only one for her. For me, she may be the fifth case of the day, but I understand that I am the only one for her as on that day in that moment. So I have to keep giving myself this, this morale boost. We also crumble. We also feel bad. I have to break this news to a 32-year-old lady with 2 little children. I mean, to tell her that she has a cancer, and believe me, young cancers don't do well. I know everything, but then I have to put up this brave face, and I have to be that pillar of support in that moment to her. I cannot be emotional. I cannot be sympathetic. I have to be extremely stoic, put this across to her, but at the same time be empathetic to her.
Very
Give her
true.
all that support.
Yeah, very well mentioned that you said empathy, because you cannot be rude, you cannot be stern, you cannot get angry. These are some elements which I think a doctor plays a vital role in dealing with emotions for her own self and for the patients. You're not only dealing with patients, you're dealing with patients' family, and they can get hyper, they can get angry. So how do you deal with the patient's family? More than anger and angst or depression, they get very hyper. So
you have to just calm them down, keep talking, and then that is what that is where all the other things that we do, that we need to do as doctors come in. Even as doctors, because I don't know if I can say this, but this is a lot of negativity. If you're telling her when she has a cancer, she's sobbing, she's crying, the husband breaks down, the children are devastated. So it's not just the patient. When it's cancer, it is the entire family. So you are breaking the bad news. So for me to gather that composure, that strength, I have to train myself to do that. I have to work on myself. Each one of us has a coping mechanism. For someone, it may be meditation. For someone, it can be fitness, running. For someone, it could be nature walks. For someone, it could be music. But we need to look at something beyond the physical to be able to gather that kind of balance and composure, to be able to handle these patients at the same way at 9 a.m. in the morning to 4 o'clock in the evening. You must remember that as doctors, we are human. We also have a family to go back to. I cannot allow this to affect my balance of mind when I come back to a family which is waiting to, share their day, how their day unfolded. So I got to have that patience, not just with my patients, but also with family. So for me personally, it is music and meditation, which I believe gives me that strength and the love of the work that I have. I just love what I do. I love what I do, and I believe this is the purpose of my life. I keep reminding it. Yes, we have our good days, we have our bad days, we have very difficult patients, but then we just got to sit down, calm down, give ourselves that 10 to 15 minutes, take a deep breath, go back and attack the next day, right?
Yeah. Like Dr. Srikala just mentioned, it is what is very, very visible in her talk. As she comes, she's not just a doctor who likes her job, it's the passion that drives her. It's very visible on her face and eyes. That's passion is what drives her every day, irrespective of the disease that she's going through, or she's treating patients. I'm sorry, I'm not going through, but treating patients and their families that they deal with. It is the passion, like she very rightly said, she deals with a zillion amounts of emotions of her own self, dealing with patients, dealing with families, because it's not easy to tell a patient who's just walked into her clinic saying, hey, you got cancer. And nobody in cancer today, till date, despite technology advancement, is still a very forbidden forbidden word.
Word.
Srikala, lovely talking to you. My next question to you is, what do you suggest, advise the young medical students who want to take up medicine, become doctors, not necessarily radiology, but become doctors as neuroscience, gynecology, etc. What is the advice that you would give young doctors?
As I said, and as you said, passion is the key word. And you must remember, you should not, studying medicine entails studying for at least 6 to 9 years. 6 plus 3 plus 3, about 9 to 12 years before you come out as a specialist or a subspecialist. At least 12 years. So you're giving 12 years of your prime life to this subject. So obviously, I need not say that the kind of passion you should have, that it has to be immense, and then you should be willing to work hard, and you have to have compassion, because here these are people. These are people in flesh and blood. These are not computers. These are not brick and mortar. These are not wires, right? These are not cash. These are not papers. These are people in flesh and blood with emotions, sentiments, and you cannot deal with them as a job,
Also, you cannot deal with the same with different patients in the same manner.
The same way,
You have to deal with the different